Oh, look, she's logged in.
Good morning, everyone. This is Caleb Cage, Chair of the COVID-19 Mitigation and Management Task Force. We're going to call to order the October 22nd, 2020 meeting of the task force, and we will begin with roll call.
Caleb Cage.
Here.
Richard Whitley.
Here.
Terry Reynolds.
Here.
Jamie Black.
Here.
Justin Luna. Felicia Gonzalez.
Here.
Brett Compton.
Here.
Megan Worth Ranson. Here. Chris Lake.
Here.
Dagny Stapleton. Wesley Harper.
Here.
Mark Pandori.
Here.
Kyra Morgan. Lisa Sherrick. Julia Peak.
Here.
Melissa Peak Bullock.
Here.
Melinda Southard.
Here.
Leslie Mullenkamp. And for the record, Samantha Laddick.
Here.
You do have a quorum.
Great, thank you, everybody, and welcome back. We're going to go now to public comment, and Randy, if I could get your assistance in public comment, but first I'd like to read the agenda item here. No action may be taken upon a matter raised under this agenda item until the matter itself has been specifically included on an agenda as an item upon which action may be taken. Public comment will be limited to 2 minutes per person at the direction of the chair. I'll be running a stopwatch here and keeping everybody to 2 minutes from the beginning of your remarks. Comments will not be restricted based on viewpoint. Instructions for participating in public comment are on the agenda. And Randy, if you could check to see if anybody would like to provide public comment, I'd appreciate it.
Good morning, everybody. If you have one this morning, please provide public comment over the phone. Mute your mic by pressing *6 and state your public comment.
Is there any public comment at
Good
this
morning.
time?
Good morning.
Go ahead.
Yes, this is Deanna Forbush. Good morning. This is Deanna Forbush. I'm an attorney in Las Vegas with Fox Rothschild. I had the pleasure of addressing the task force last time we met on October 6th, or 8th, I believe. I spoke to you advocating the opening of lots of brothels in my county. I'm getting a lot of feedback. Can you hear me?
Yes, I can hear you fine. Please continue.
Okay. I spoke to you advocating the opening of lawful brothels in my county. It's now been 2 weeks since I addressed you, and over 7 months, our employees and contractors were left without work or any viable way of supporting themselves or their families. The governor continues to ignore our industry and those that depend upon it. He continues to fail to provide any rational basis for our continued closure. As I mentioned before, all that we've been told is that the governor is not focused on us and does not like skin-on-skin activity. Meanwhile, massage therapists, dentists, hygienists, plastic surgeons, tattoo and piercing parlors, spas with waxing, threading, facials, and hair salons, nail salons, and even eyelash spas are open. I previously addressed the unconstitutionality of the disparate treatment demonstrated so far by the state in its subjective decisions that result in the picking of winners and losers. I also outlined the growing number of lawsuits filed against states around the country that have reversed these unconstitutional actions and expressed my opinion that the same thing will happen here. However, I want to be clear that my client does not want to join the long list of businesses that have sued the governor and this state for their unconstitutional actions. We do not want to be part of the problem facing this great state. We want to be part of the solution. We want to get the thousands of people that work in this lawful industry back to work so that their families no longer suffer. And we want Nye County to again become prosperous with the economic activity our businesses generate. Please help us do that by issuing one more directive, opening our businesses and putting our people back to work. Thank you.
I apologize, I'm muted on this end. Thank you, Deanna. We appreciate your comments, and sorry for the interruption there, but we did get all of your comments on the record.
Thank you, Caleb. Thanks very much.
Yep. Is there additional public comment at this time?
Chair, no one has unmuted to say public comment.
This is Caleb Cage with the task force. I'm going to call again for public comment at this time. If you have public comment to provide, please press *6 on your phone and provide your comment. Okay, not hearing any other public comment at this time. We will have another opportunity at the end of the meeting to provide additional public comment. We appreciate everybody's patience with this, and Ms. Brems, thank you so much for coordinating that for us. I'd like to close out agenda item number 2 and move to agenda item number 3, the approval of the minutes. These minutes have been provided extensively. They're a large document from the meetings that we held on October 8th, and I'd like to thank Megan and the staff and Tanya Benitez from HHS for working so hard to put these together. They're comprehensive. I believe they cover the meeting well, but I'd love to have a conversation now or entertain a motion to amend or approve under this agenda item.
Caleb, I'll move to approve the minutes.
Terry Reynolds, Director of the Department of Business and Industry, has made a motion to approve the minutes as written. Thank you very much. Is there a second?
Christopher Lake will second.
And a second by Dr. Lake. Thank you very much. Is there any discussion? Hearing no discussion, I'll call the vote. All those in favor, please signify by saying aye.
Aye.
Aye. Any opposed, vote no. Great, thank you very much. And again, thanks to the staff for putting those together. Let's move on to agenda item number 4. And it occurred to me when I was approving, after I had approved the agenda this week, Dr. Lake, that I thought we used to have a hospital association update on here, but we may not have. Would that be something that you'd like to have an opportunity to provide a presentation on during agenda item number 4 in the future?
Yeah, that would probably be beneficial.
Okay, apologies for doing that. I know you've been an active participant in these meetings, but we'll go ahead and get that added back. And with that, we'll go to Department of Business and Industry to provide an update on enforcement.
Caleb, thank you. This is Terry Reynolds with Business and Industry. A couple things to point out here. We have a little lower first visits this time, but that's because we're concentrating on construction back to that area. And when we originally started out, construction has always been open, and we had some large projects going, and we were focusing in on that. We backed off and done more retail, commercial in the last several months, and so we felt it was time to go back to construction. We found that generally things were a little lax, and so we were picking that up. They're responding well. That's the good news to that. So I just wanted to point that out. The other thing that I think was interesting is that we've had, and we've been working with both Reno and Churchill County and Fallon. We've had a little lower compliance there. We are going out and doing a joint inspections with the city of Reno and their people in the next week or so. And so that's very positive. They want to kind of get a feel for what we're looking for and then what they're looking at. And we're going back to some of those areas where we knew that we had some compliance issue problems with certain businesses. So that I think is going well. And we really, stepping up with compliance with them. And I think they'll get an idea of what the types of things we're looking at and the types of issues that we see. We've also been working with Clark County and the city of Las Vegas. In fact, we had a couple businesses that they felt that were basically pumpkin patch type businesses that weren't following the protocols. And so we're working with them to try to get them into compliance. And if they don't over a period of time, then the city is gonna actually take their permit away for those type of activities. So hopefully we won't get to that point, but I think that's an important step in terms of working with the local governments and trying to get compliance. The other thing that we're doing is we're with the new directives, both 33 and 34. We're reviewing and approving a lot of events. We've had we had a backlog of them. We had almost 100 submittals within the last 10 days of different events that came under both of youth sports events, and that's going actually fairly well. We did have some early submittals that we could use as templates that were outstanding. The city of Henderson has done a very good job The youth soccer groups have done a very good job in terms of putting together very solid plans, and we had some examples to get out to different counties to look at. This is what we feel is a good active plan. So that is ongoing and fairly successful, although it's there's a lot.
Mm-hmm.
So, but what we're doing is like an overarching safety plan, and as they come in and for those groups, they'll fit into that overall safety plan, and then we'll look at their events. So that speeds things up. Once they get that overarching safety plan in for their league, then we can go through and just look at specific events. And we're working very well with Washoe County and Clark County and having some feedback and questions answered back and forth with them to try to get consensus on different events. So that's working well.
That's great, Terry. And this is Caleb. I appreciate the update. We had a call yesterday or recently that Administrator Carrion was on, and she and her team, I just want to commend you for your leadership there, and her team just doing an incredible job. She brought up the sort of huge number of events that they're reviewing right now, and I don't know how we could provide resources to assist, but that's a critical role. And if there's something that we can do, if there's a discussion we need to have about bringing on more people to review, or and again, I know that OSHA is its own functional area, but if there are things that we can do to support you, support gaming, and other agencies' health that are we're these, I'd be happy to have that conversation.
Yeah, and we're willing to accept that too. When we get to that point, we're having that dialogue with our staff and making sure that we can keep up. But if we see where we're getting backlogged on that, Caleb, most definitely, and I appreciate that. And I think from Tori's end too, she would appreciate that, and trying to make sure that we are diligent and get these through. We want to make sure that we can accommodate these events. We have not had a lot of, starting to see those with larger convention events, but we are getting a few, which is good news. We want to see those. And I know Gaming Control's working on them, but they haven't got the flood of events that we have in the last few weeks, but I think that it'll start. Hopefully things will pick up. So we're willing to help if you need any technical expertise. Our staff is willing to help on that. But so far so good.
Great. Thank you. I appreciate that, and thanks for the update, and especially for the work that you all are doing. Does anybody have any questions or input for Director Reynolds? Okay, great. We're going to move on to Division of Emergency Management, and Megan is going to read an update from Chief Luna. Is that right?
Yep.
Go ahead.
Per Chief Justin Luna with Division of Emergency Management, all orders have been placed. The 100-day quantities are already on hand for all categories except for gloves and face shields. DEM anticipates delivery of face shields to reach the 120-day quantity goal by the end of October, and deliveries for gloves to reach the 100-day quantity goal by the end of November. And then if you have any questions, please reach out directly to Justin.
Great, thank you. And we received those updates internally on the PPE purchasing, as well as on the collection kits for the tests as well. So I know that we've been working for several months. They've been working for several months to do that. So thank you, and thanks to Chief Luna for providing that. I know that we were not able to get Ms. Mullenkamp on, and we're competing with the Interim Finance Committee today, which is not intentionally counter-programming ours, or we're not intentionally counter-programming them, but it's just the nature of schedules. So at this time, I'd like to go ahead and go to Deputy Superintendent Gonzalez with the Department of Education.
Good morning, everybody. Felicia Gonzalez for the record. I don't have any additional reports today. I hope that during our next meeting, I'll be able to update you on some charter schools and some school districts that are looking to change some plans and have more students return to in-person learning. Thank you.
Thank you, Deputy Superintendent. Any questions or comments for Felicia? Okay, hearing none, we'll go to Chief Jamie Black with the Gaming Control Board.
Thank you, Caleb. Good morning, everybody. Jamie Black for the record, Nevada Gaming Control Board. Similar to what Director Reynolds reported, the board has been diligently implementing its large gathering review and approval process. So far, things are going fairly well. We're working with our regulatory partners, which is ongoing. We do want to specifically thank Business and Industry for its collaboration with the board. It's been very helpful throughout this process. With regard to our inspection and compliance checks, as of October 16th, the board has logged 199 regulatory violations. So we're only up one from our last report. And as of 10/16, also, the board has conducted 848 inspections and compliance checks. And end of report.
Thank you very much. Appreciate that. We'll go now to, well, the Association of Counties. I know Dagny is at Interim Finance Committee, so we'll go to Director Harper with the Nevada League of Cities.
Thank you, Caleb. Nothing to report. Thank you so much.
Thank you. Appreciate it. So just a note, Chris, I'd love to get an update from you right now, but we do need to make sure it's agendized and we can talk about it in the current situation report that we're going into right now. I know that, and we'll make sure that's added in the future. So unless there's any further discussion, I'd like to go ahead and close out agenda item number 4 and move on to agenda item number 5. And under this item, we take the opportunity to look at the data for COVID-19 in the state and hear from some of the counties that have provided reports. And we're going to do Washoe County first. And Health Officer Dick in Washoe County, I did receive your note, and I apologize for not responding, but we'll get to you first, and we'll get to you first on the update on safe gatherings under agenda item number 6 as well, to accommodate your request. So at this time, I don't know that I heard Hyra, but do we have a presenter to talk about the current standings? Melissa, can you provide us an update on that?
Yes, thank you, Caleb. Melissa Peak-Bullock for the record. We can get started on the presentation. I don't know if you're pulling up the slides or not, but I'll get started with the first slide, which really looks at a summary of our current status, indicator status, and this is data as of October 21st. And first you'll see here for our daily new cases is at 500 over a 14-day rolling average. We're at 440 cases per 100,000 over the last 30 days. Our total cumulative cases is 92,064, and we're at 2,847 cumulative cases per 100,000 population. And moving on to deaths, we're seeing 4 new deaths reported daily over a 14-day rolling average. We're at 5 deaths per 100,000 over the last 30 days. Our total is 1,732 deaths with 55 cumulative deaths per 100,000 population. In terms of testing, we're currently at 227 tests per day over the last 14 days. Our test positivity rate over the last 14 days is at 9.3%. And you'll see here that our cumulative tests are over 1.1 million. And then next slide. Okay, this slide is looking at our confirmed and suspected hospitalizations. And you'll just notice here on this first graph, sometime around mid-September, the trend for hospitalizations remains relatively flat. There's no significant increase or decrease that we're seeing over time. And then next slide. And this slide is looking at our 14-day positivity rate trended over time, and this is overlaid with the 5% WHO goal. And the takeaway here is that really since mid-December, again, we're seeing a slow and steady increase in our test positivity rate. And again, at 9.3% over the last 14 days. And next slide. The next slide is looking at COVID-19 testing turnaround times. This is data from September 1st through current. And this is broken out by individual labs and also by individual counties. You'll notice in total, there's an approximate 2 days after specimen collection to results reported across the state. We have had some feedback yesterday evening that it may be beneficial to show this data in 2-week increments to really see what's currently happening. And there is discussion going on with Kyra's team and Office of Analytics to accomplish that change. And the next slide. This slide is really as reference. This was the county tracking data as of the last task force meeting. You'll notice in the red circle, it was last updated October 5th. This was using the previous criteria, and at that time, both Humboldt and Washoe were flagged. And moving on to the next slide, we'll show our current county tracker data. This is data as of October 19th. And you'll see here that we have Clark, Elko, Lincoln, Lyon, and Washoe counties all flagging. All of these counties are flagging for the same criteria, and that's cases per 100,000, along with the test positivity rate. I do want to just point out that, again, we're seeing more transmission within the state overall. Also, for some of our small counties, Lincoln County, as an example, their data is going to be more sensitive to fluctuation due to their small population size. So we do know of a couple clusters going on in Lincoln County right now that is affecting their county criteria. And then moving on to the next slide, and really these next 3 slides, they're showing the county criteria data over time by county. And at the bottom of each slide, you'll notice a trend line for each county. So this one is just looking at that criteria, again, by county over time for testing criteria per day of 100,000. And then the next slide is exactly the same, although it's looking at the case rate per 100,000. And on this one, I really just want to draw your attention to those bottom trend lines. I think this one's more evident that when you look across those counties, that you'll notice that most of those counties, the tail end of that trend is moving upward. And next slide is again the same, the data trended over time, but this one is looking at test positivity rate by county. And that's the end of my current situation report.
Providing that overview. Thank you to whoever just unmuted me. This is Caleb Cage for the record. Thank you for providing that overview. I want to point out a couple of things here before we get to Julia to provide her update as well. And first, I think it has to be the first week that we've reviewed this information off of the new dashboard information, which we received an update on last time. And I saw Kyra had done some media around this, answering questions on it. I think she's done a fantastic job, not just with explaining the changes to the dashboard, but also the changes to the dashboard themselves. This is incredibly more useful. Not that the last time wasn't, or the last version wasn't useful, but this is incredibly useful to me to look at these trends. I'll point out that slide 8. One of the things that we received requests for and have received continual requests for from our local partners was to make sure that this slide was public and not just something that we kept internally. And so this update to the dashboard has allowed us to do that. Also, if you go online and look at the counties on a daily basis, you'll see that this updates on a daily basis. And just to be clear, we're only going back to the Monday of every week to determine whether or not a county is flagged. So I think the overall story here, and we've got the state epidemiologist here to correct me if I have this wrong, but the overall story here can be seen on these slides, is that we are experiencing an increase in cases. I don't think there's any way around that, whether we're looking at cases or test positivity or other factors. The good news is hospitalizations remain relatively steady, and our ability to address the virus from the state and local standpoint is increasing well. I'm also just very pleased at the average turnaround time for tests. The maximum on slide 6 is 7. It looks like to me. I don't see any 8s, and that's usually that used to be formerly the low end. So that's now the high end. That's good. So we'll continue the conversation here. We'll go to Julia right now to provide an update on contact tracing.
Perfect, thank you. We've now identified a total of 24,106 total cases as a result of our contact tracing effort. That's now a high percentage of 26% of the total cases reported to date. As you all may have seen, CDC revised their definition of close contact. Still 15 minutes within 6 feet, but what they've noted now is that the risk of contracting coronavirus includes people who have come in close contact with infected individuals in short periods of time over a 24-hour period. I'll note that we are going to incorporate that as part of our disease investigation through traditional sources, but this was already developed as part of the COVID Trace app. It was already providing those Bluetooth notifications for short periods of time, not just a single duration of 15 minutes. So again, encourage everyone to download that app. We're now at 54,159 total downloads. We've had 8 cases that have had the app downloaded now at the time of their diagnosis. And as a result, 15 exposure notifications have been sent to date. Another thing that we're working on in disease investigation is that a large number of our projects have been funded through the CARES Relief Act. Those funds end on December 30th, but we do have our epidemiology and laboratory capacity grant that's funded for the Centers for Disease Control and Prevention. That grant is one of our longest. It runs for 30 months since the date of that award. And so we're moving to a more sustainable model after December 30th. So some of the things that we're working on actively now includes developing a statewide communicable disease database, of which it includes COVID, as well as the other reportable conditions in our state. In the past, we've had 2 separate systems for the Clark County region and then the rest of the state. And so our partners at Southern Nevada Health District, along with our other county and state partners, are developing that database. This will be a great benefit to public health ongoing. Southern Nevada Health District already supports our syndromic surveillance system statewide and have done a great job. We're also looking at changes potentially related to our surge staffing, as a bulk of these efforts are funded through the CARES Relief Funds, but we do plan to continue to work with our Nevada system of higher education, and our local health departments are hiring and training local staff to provide disease investigation locally, again, for the duration of 30 months. I do want to take a moment, certainly last but not least, to acknowledge 2 Frontier County health officers who are leading the effort, Wanda Nixon in Mineral County and Brandy Bengoa in Lander County. It's been a pleasure to work with both of these ladies on COVID, and they leave very big shoes to fill. And so I want to acknowledge them on record officially right now. With that, I'm happy to take questions.
Thank you, Julia. Are there any questions or comments from the members of the task force on either of those updates? Okay, hearing none. So we know the situation here in the state of Nevada. We've been over that and appreciate all of the hard work that's been there. And yes, thank you. Who is the other?
Wanda Nixon in Mineral County and Brandy Bengoa in Lander County. Both of these ladies are phenomenal.
And you said they're moving on.
Yes, they've decided to leave their role as county health officers.
Okay, well, we'll have to express our thanks to them. They've both been excellent throughout. So with that, I'd like to bring up Washoe County as the only agenda item on this action item for us to discuss here. And Washoe County, as we all know, has been flagged for recent counties for at least meeting at least two of the criteria. We've had a number of conversations with the health officer and the county manager and county leadership on this to discuss this, but I'd like to turn it over to Health Officer Dick right now to provide an overview of where you stand and have a discussion about any of the elements within your action plan that we may be able to address or support or otherwise. Kevin, are you on?
Yes, good morning, Chair Cage. Can you hear me?
Yes, sir, loud and clear. Go ahead.
Great. And I appreciate your consideration of my tight schedule today. So thank you for that. I provided the county provided the Washoe County assessment for this past week, and we also provided an assessment the week before to keep everybody up to speed. But what we're seeing is a surge in cases that's occurring in Washoe County. We reached a high of about 127 new cases per day with our 7-day rolling average on Tuesday of this week, October 20th. That was a 27% increase in new cases from the previous week and a 57% increase over the 2-week period. So a significant rise in cases that are occurring. We're continuing to see the highest number of cases per 100,000 for the age range of 20 to 29-year-olds. But it's, I think, also significant that we're seeing an increase in cases that are occurring in the sort of the 30 through 60-year-old range as well. And I think that's consistent with what has been found nationally in looking at cases where you have the increase in cases of younger population kind of occurring earlier as the surges happen, and then having that number of cases in that 20 to 29-year-old population leads to more spread occurring into those other age ranges. The hospital capacity, I noted that we do have, our hospitals are fairly near capacity, and it's not reflected in the Nevada Hospital Association numbers on capacity because those are been calculated based on the licensed beds versus staffed beds. That was done when there was a surge and hospitals were having heavy utilization down in southern Nevada, so that the statistics could reflect hospitals that had surged to provide beds beyond their licensed capacity. But the staffed beds are fewer than the licensed beds, and as a result we had hospitals that had filled up ICU units earlier this week, and with their emergency departments going on divert as a result of that. So that's not driven specifically by COVID. The COVID-19 cases in the hospital are a fairly low burden on overall hospital capacity, but it's just the other activities that are normal activities with elective surgeries and people becoming sick or injured, et cetera, that are impacting that. I did note that the number of tests per day, as far as tracking over this past week, appear to decline, still well over the threshold of 100. We calculated 219. But just wanted to note that I believe that that's attributable to the way that the data reporting was changed by the state website to only count once individuals that are tested using a rapid test and a PCR test where the specimen collection is done on the same day. And I think that's an appropriate correction to be made in the way the data is reported. But that scrubbed over 2,200 tests to date from the system, and with the data we're using, it did result in that reduction, apparent reduction of testing because of that correction that was made on the data. We continue to try to respond with the surging number of cases with our contact tracing efforts, but you'll note that we've fallen behind week over week from a 53% of the cases investigated over the course of a week to down to 37, and we're working hard to try to catch up, but with the surging case numbers that we have, we're being overwhelmed with the disease investigation efforts, and we really need to have people being careful to protect themselves and others when they're out and about to try to drive down the spread that we have occurring. And that's a spread that's happening from people being out in their workplaces, out doing their errands, grocery stores, social gatherings that are occurring. We have people that have visited restaurants, have traveled, gone to gyms, churches, casinos, and bars before they become infected. Not that that's pointing specifically to that was the cause of their infection, but we do have a lot of community spread, and the highest that we've seen to date occurring in the community. The highest number of cases that we've seen over the past week have been associated with K through 12 students and school district staff as far as a specific type of organization, and that's an increasing number of 70 cases that have occurred over the past week. We have had an outbreak occur at the Salvation Army Adult Rehab Program. That's a congregate facility with 35 cases there. And the University of Nevada, Reno, while they're in our list of organizations with more than 4 cases over the past week, with 34, that is a decline in number of cases. And I'd like to believe that President Sandoval's actions in the Protect the Pack initiative, closing the fitness center, et cetera, and the messaging to the students has assisted with that. What I'm hearing from the disease investigations is that they believe that most of these cases in UNR students are probably occurring from workplace exposures, and they're not hearing of as many social gatherings occurring that people attended before becoming ill. The detention facility that the Sheriff's Office has for Washoe County has had a number of cases that were just announced yesterday. So they are responding to the 11 inmates and 5 staff that they have identified as positive. They note that they've tested 276 inmates and 16 employees over the past 48 hours, and we're providing them with additional test collection kits, and they're going to be continuing to test through the jail population and their workforce to try to get that situation nailed down and mitigated. With the Halloween gatherings and Dia de los Muertos, Nevada Day coming up, we're messaging on avoiding social gatherings, and if they do occur, reminding people of the governor's directive that limits that to 10 individuals for private gatherings indoors, or a maximum of 25 if people are outdoors. I did note in the report the action that we took in regard to the Governor's Directive 33, that we're not going to approve any indoor gatherings of more than 250 people until we have the opportunity to see where we're at 30 days in to those gatherings of under 250 being allowed to occur. And based on the number of new cases that we're seeing, the surge that's happening now, it's not likely at this point that we're going to be able to move forward with approving those. We did take action to allow the Greater Nevada field to open at a capacity of 700 based on their performance with a crowd of 250, and our belief that it's a better environment outdoors with fixed seating venues to be able to allow the larger gatherings. Unfortunately, the FC 1868 lost the match on the 17th, and as a result, there will not be any more playoff games. We're working to provide flu pods to try to maximize the number of people that we can have get vaccinated for the flu this season, and we're working together with the state on planning for dispensing of the COVID-19 vaccinations. And I'll turn it over to Manager Brown to talk about the enforcement actions and the marketing campaign that's underway. Manager Brown, are you able to join us? I'm not hearing Manager Brown, so let me just follow up that the enforcement activities are continuing with City of Sparks, City of Reno, and Washoe County. As Terry Reynolds noted, there's a closer coordination occurring with the OSHA program on the inspections, and looking for consistency with those activities. There is a task force, enforcement task force, that's been formed through our incident management team to kind of formalize the way in which the jurisdiction and enforcement programs are working and working together in a unified approach to this. The campaign that the region has been working to develop has had a soft launch. It's the Mask On, Move On is the campaign to encourage people to wear masks and appropriately social distance. There's a specific focus area. We've got several different focus areas, but a major one being the Hispanic population, that 20 to 40-year-old age range as well. There is some component for our elder population, the vulnerable population as well with that. So there's some Facebook stuff and it's begun already. Website that's going to be launched soon with a new look for that. And then the advertising campaign should really ramp up after November 3rd, where we won't be drowned out by all of the campaign advertisement going on, and we'll get, of course, better rates after the election's over. So with that, I'll conclude my summary, and I'll be happy to take any questions, Chair Cage.
Thank you so much, Kevin. I appreciate all the work that you put into this. I have two areas that I'd like to discuss with you, and then while we're doing that, we can talk about any needs you have from us and have members of the task force join in as well. The first is on the second point on page 1 and page 2 of your assessment, and which is always very well done, and I appreciate it. There's a line on page 2 that says that talks about hospital surgeon capacity, licensed beds versus staffed beds, and those sorts of things. And there, I want to make sure we get to we have the conversation about the discrepancy that you noted there, and maybe get some input from Chris Lake on this as well. Can you, for me and others who don't work boots on the ground every day like you do with this, can you explain a little bit more about the discrepancy between licensed beds and occupancy or capacity that you're talking about in the first, I think, just really the first paragraph on page 2?
Yeah, and yes, I can, and I'd like, Chris Lake, please jump in to the conversation. But as an example, for this, for instance, with Renown Health, they have, I believe, 808, somewhere around 800 licensed beds within the hospital, and but the staff beds at the hospital, I believe, are closer to 600 at this point. So if you look at available beds, when you look at licensed beds at 800 and you look at the number of occupied beds, then it looks like you have a lower percentage of the beds occupied. But if you look at the number of beds that are staffed, 600 or so, and your occupied beds maybe at 90% of that number, then that shows you that you're really reaching capacity of your staffed beds. And so there was a good reason, I believe, for why change was made when we were surging to be able to identify hospitals that had gone beyond their licensed capacity, because that would show that they had surged beyond 100% of their beds. But the downside of it is before you get to surging, it makes it look like you have more capacity than your staffed beds support, and it can be difficult for the hospitals to staff up quickly in some circumstances. But I'd like to see if Dr. Lake has a comment on that.
Yeah, absolutely. Thank you, Kevin. You're absolutely right. We actually used to report that as a percentage of staffed beds as opposed to licensed beds. And back prior to this commission, when we were doing the GUB calls at the peak, it became very complex because trying to demonstrate surge capacity in which hospitals had the ability to add staff and treat patients within their licensing versus who didn't have the ability to do that. It just became difficult. It became complicated to explain the difference between a licensed bed and a staffed bed. But we can definitely add that back at this point in the pandemic. And as we start getting back into, flu season is among us and gonna start competing for these beds as well. If you as a health officer think that would be a beneficial metric to put back on the daily graph and on the table that we do, I'm absolutely willing to do that.
I appreciate that, Dr. Lake. I think that would be really beneficial for us. We've actually kind of stepped up our communication and coordination with the hospitals to try to stay on top of this. But if you're able to provide that with your reports, that would be very useful. Okay, absolutely. We'll throw that on. I'll see if we can start that tomorrow. If not, as soon as we can work that into the computer routine, we'll do that for you. Appreciate it. Thank you very much. Absolutely.
And Chris, this is Caleb. I think one of the things that I've learned throughout this is that, and correct me if I'm wrong on any of this, but one thing that I've seen throughout the pandemic is that hospitals typically staff to about 75% on average of their overall capacity. And when, again, in aggregate, the surge was really big in Clark County, for instance, in July, early August. I think the highest that the hospitals really got for capacity was up to about 82, 83% or something like that. And then they were able to staff up to that and bring those numbers down. So I think that's a part of the business model, for lack of a better word, and seeing that number, I think, will provide good information, actionable intelligence for everybody. And it's important too, because the staffed bed requires staffing, right? So that's a whole new resource that has to be brought in. And I know that's something that your members are very well aware of and very adept at addressing. So I appreciate that conversation.
Yeah, absolutely. Yeah, the one thing I would want to point out for those that don't understand is the hospitals don't ever staff to 100% of their licensed beds, and it's like any other business. They staff to the amount of work that they have on any particular day. So staffing is flexible. You will see that change, and having a staffing pattern of about 75 to 80% is not abnormal for hospitals. You will see that. What becomes problematic, and what we saw in those that time period, that late July, early August, was when it gets to the point, particularly with the ICU, where it becomes difficult to get additional staff. And that became a problem as New York was also surging, Texas, and the entire nation was competing for those nurses and specialized medical practitioners. But with those caveats, we'll put that we will definitely put that back on the report to help out. And anybody who has questions regarding those numbers, feel free to reach out, and we'll try to answer those.
Great. Thank you, Chris. The other item that I wanted to touch on, and Kevin, thanks for indulging me on this, was in the action plan portion on page 11 under item 7. And we recognize, and you and I have had this conversation, we've had a broader conversation about Directive 33, and I commend you and your organization's decision to maintain the events over 250 people not being approved by the health district until you have the opportunity to assess. I know that's a difficult decision, and I know that there's a lot of pressure and all of those things. So you mentioned in there that, or I can't remember where you said it, you may have said it elsewhere, that there's not really an appetite for for reducing that or prolonging the reduction over time. And I just want to make sure that that's at the county and city government level. And I'm not trying to throw anybody under the bus or anything like that, but is there support that we can provide here from the task force or otherwise in order to make sure that we're supporting you there for that decision and the other decisions you're making with respect to the public health of your community?
Well, I've expressed my concern that I don't think it's with the surge that we're seeing, the appropriate time to start having the larger gatherings. But it might be useful if the task force wants to discuss that, and if the task force has an opinion or recommendation on that, I think that would be useful to hear. Sorry, Caleb, did you hear me?
Yeah, I keep doing that. I'm trying to mute it so you don't get background noise here, and I'm talking to myself and the people who have to hear me in the room here. So my apologies. So yeah, let's have that discussion here, and we've got a plan and an action plan and an assessment. And again, appreciate, Kevin, your work in doing this, putting this together. And we do have an action item to vote to approve it. And see if there's any input from the members of the task force at this time.
So Caleb, this is Terry Reynolds. Couple comments on this. One is that we really appreciate the work that Washoe County has done, and also working with Manager Brown and his enforcement people, and they've really been diligent in keeping up on that. We're now seeing fairly good cooperation between with Reno and Sparks also, and that's very important, is to work in tandem with the county and the cities to be able to make sure that we have good enforcement, and that we look at those areas where we're seeing growth in cases. So that is ongoing. I concur with Washoe County's effort to hold back on these large gatherings, and under the directive, as you know, they have the ability to do that, and they are doing that. And they're probably taking some flack for that, but I think it's the right thing to do in terms of that. So we're seeing just in a lot of areas that things are being a little bit lax, and so we're trying to tighten that up. And I think Washoe County is aware of that, and with the enforcement efforts that they're doing, with the marketing impact area they're doing too. But we are seeing private party gatherings. We are seeing the impacts of that, and as he's correctly put out, that affects not only people that transmit, but then they bring it home, and then they have additional cases because of that. So we're seeing community spread because of that. There's no great answers, no easy answers to this, but I think the more you can hold things right now in that regard, meaning trying to keep the standards enforced, keeping people aware of the things that they need to do to prevent community spread, the better off we'll be. And I think you'll see the caseload start to trend back down again. But if we don't, and people are lax about it, it's going to come back up again. And this is not the time of the year. I know we have a rather large workforce in BNI, and I'm seeing colds, and I'm seeing employees get sick, not COVID related, but we're seeing that with our employees, and so it does happen. This is the season, and so we need to be fairly diligent in terms of watching our households and watching our employees and making sure that people take care of themselves.
I appreciate that, Terry. I think you're right on. You mentioned that earlier in your comments about, you're not trying to slam the industry, but going back out and finding, readdressing construction sites and that sort of thing. And I think that's the vigilance we need, right? I mean, the nature of compliance with situations like this is that it likely will get more relaxed over time. So I think that's a really great reason to be going out there.
Yeah, we're putting out a memo back again to all our employees and our supervisors and division heads to say, here's the things you need to keep on doing. You need to be diligent in making sure that our employees are following up and doing the things that they need to do to stay safe and comply. So, I think everybody has that responsibility to do that, and I think that's the most important thing we can do as employers or as our groups, to make sure that we are diligent in what we do to suppress this.
Appreciate that. Any other members of the task force like to provide input on this? Okay, hearing none, I would like to, in support of the health officer and his decision to delay the 250 person events, and as well as, and I know this isn't in your report or in your direct jurisdiction per se, but you mentioned earlier the actions going on at the university to prevent the spread there as well. And so if there's no further discussion, what I'd like to do is offer a motion to approve the plan as provided in support of Health Officer Dick's decision to delay the gatherings of up to 250 people and to otherwise support the university and other local leaders' efforts to address the spread.
This is Terry Reynolds. I'll second that motion.
Great, thank you, Terry.
Thank you.
Is there any discussion on the motion as it stands right now? Hearing none, all those in favor, please signify by saying aye.
Aye.
Any opposed? Sorry about that. Any opposed, vote no. Okay, motion carries. Thank you very much, Kevin. I appreciate your work on this as well. I'd like to see if we have anyone from Elko County or Clark County. Let's see if we have anybody from Elko County who'd like to provide an overview. This is not a part of the action item, so this will just be information only for both Elko and Clark. Amanda or anyone from the Elko community who'd like to provide an update to the task force at this time? Okay, great, thank you. We'll go to Clark County and see the same.
Morning, Chair Cage. This is Billy Samuels.
Morning, Chief Samuels. Go ahead, sir.
Okay, so myself and Chief Steinbeck in the office, just kind of go over our plan. We had that same concern that Kevin Dick was talking about, staff beds and licensed beds with the hospitals. I had our medical surge area command. We did a hospital all-call on Tuesday just to kind of to see how the hospitals were feeling with their surge. And they are extremely comfortable and adamant that they can handle any needs that are thrown their way. Their staffing is great. Their ventilators are so underused. I think they're at like 23% or 30%. That's not even there's no issue that our hospitals have. I know our percentages are going up, our positivity rate, but as you guys can also see in the report that we submitted, the testing that we've done on October 10th was 9,300, and then on the 13th we had 14,000. So we're not really seeing a very huge decline in people wanting to do the test anymore. That's kind of got back up a little bit on us. Again, our sites have been working hard with their the testing of the residents. So just trying to make you guys, I know the numbers look bad as far as positivity rate and cases per 100,000, but our hospitals are definitely here to still be able to take care of the needs of the community. I think that's probably one of the most important things that we can look at. And with the treatments, the patients aren't in the hospital as long as they were in July and August. With the quick treatments, they're out in several days as compared to several weeks, which is why our hospital capacity is still very strong and stable. And that's all I have, Chair, unless you guys have any questions for me.
Yeah, thank you, Billy. Our Chief Samuels, I would like to have a discussion here on this, and I think that's one of the benefits that we've seen in our data, and I know Chris has been an advocate from the Hospital Association's perspective as well, and that is, though we may be seeing more cases, we are not necessarily seeing as acute of cases as we have seen in the past. Shorter hospital stays, better treatments, resulting in fewer deaths. And I know that's not a necessarily in-depth way of discussing that. But Chris, is that something you're seeing from the Hospital Association as well?
Yeah, definitely. The other thing that we're seeing is with this virus, it's just not driving as many people percentage-wise to the hospital. So in the early days when people had COVID, we were seeing about 50% of those, or a large percentage, I should say, need hospitalization and hospital treatment. And today we're seeing, even though the positivity rates are increasing, those that require hospitalization are staying relatively stable, with only about 10% of the people in the hospital at this time being there with COVID. So I think that's a fair assessment.
Okay, great, thank you. Chief Samuels, this is Caleb again, and one of the things that I think we've received some outreach on, and of course it's in social media and in the media in general, is the number of locations that are spinning their business back up, and not the prohibited locations or anything like that, but the locations that are opening up for parties and that sort of thing in the community. And I just wanted to see, of course, you're monitoring that, and you all are seeing those things from the ground perspective. But is that changing your approach in any way, your enforcement, any of your strategies associated?
Chair, I can't speak for the business licensing themselves. We do have conversations, and I know they do. When they do hear words of mouth, they go out and look at those businesses. But also, they look at the OSHA data for concentrated inspections, and any data that they get from OSHA, if for first time, second time visits, they'll go back and review those places to make sure that they are compliant. And if they're not, then we have our policy and our mitigation actions under enforcement on this plan.
Okay, great. Terry, do you know, Director Reynolds, sorry, do you know how often Industrial Relations provides that data to the county, or is it through these meetings and through the dashboard?
No, it's on a weekly basis, so we get it out, fairly often to that, and then we send it to you, but it's available every week. So, and we have weekly meetings with the cities and counties to be able to discuss the data and discuss those areas that we find. So we're pretty good about that, I believe, in getting that out.
That's my understanding as well. I just wanted to make sure we had that discussion here. So yeah, that's really important. As we see things again, and this is open source media and those sorts of things, I don't want to overload you, and I don't want to just be throwing things in from the outside of the conversations. But if there are ways that we can alert you, or the weekly meeting that DIR participates in with you, and we also have the standing meeting with the local health authorities, there are a number of opportunities where we can have that conversation. Just want to make sure that's on the horizon, that's in your awareness, that when we are expecting an increase in cases, that's a part of where it's a part of just where we're at right now. And so we want to make sure that there are mitigation measures and strategies in place. And I know you have them. I just want to make sure we can discuss those. Other members of the task force? Okay, thank you, Billy. Good job in Clark County with your numbers and everything you all are doing. So appreciate that. And unless anybody else has anything for Clark or Washoe County, we'll go ahead and close out this agenda item. Okay, hearing none, we'll go to the next agenda item, which is an update from the local health authorities. This is an agenda item that we've added in order to make sure that we have ongoing communication through the task force, public communication through the task force, and to support our other efforts that we have in order to make sure we're communicating here. And this really is to talk about the implementation of Directive 33, and we have the local health authorities listed on here. I would like to go to Washoe County first, even though they're last on here, just to make sure we're accommodating Health Officer Dick's schedule here. But before we do that, I want to check with Carson City. I know there was a 50-50 shot that we would get an update from Carson City based on some scheduling conflicts. So let me just pause real quick and check to see if we have anybody from Carson City Health. Okay, great. We'll go back to Washoe County and Health Officer Dick, if you could give us an update regarding your safe gatherings and local health authorities implementation.
Thank you, Sheriff Cage. Can you hear me?
Yeah, I got you now. Go ahead, sir.
Okay, thanks. So I think we've discussed this a bit on the previous item, but I can tell you that I think are coordinating quite well with Department of Business and Industry on the communications on the requirements and the reviews. As I noted, we're not approving any of the indoor gatherings that exceed 250 at this point, and we don't have any outstanding requests at this point for outdoor gatherings larger than 250 in seated venues. So we're not actively involved in approving them. That said, we do have some events that have been submitted or at least one that is occurring after that 30-day period that I noted, that we're waiting to make any decision on moving forward with larger gatherings, and we're at their request are going ahead and reviewing that to provide feedback in the event that that would occur. I just would also note that we do have a fee that we're charging for that review. That's an advisory fee that we have in our fee schedule to help cover the staff time that's involved with that. So that's I think my update, and be happy if you're looking for additional information to provide that.
Well, thank you, Kevin, and I appreciate that. So with the deferral, I guess is the right way of saying it, on the events of 250 people or greater, are you seeing any activities that are people disregarding that and just going ahead and holding those events? Are you seeing any signs of that in the community?
There was one venue that we were not clear of on whether they were limiting the capacity to 250 or if they were going over that number. And we've made a referral of that, or at least I directed staff to, I don't know if it's been made at this point, to the Gaming Control Board, because it's under their jurisdiction, just to have it investigated.
Okay, I appreciate that. So but to your knowledge, there's not it's not a, for lack of a better word, kind of a Wild West where people are just out there doing whatever. There's some adherence to the 250 person or the delay on the 250 person events.
Yeah, I'm not aware of any people that are violating it. I can't tell you it's not happening, but we haven't had any reported to us, and it seems to me that the people that are trying to organize larger events have been in contact with us and trying to go through that process.
So, in your ongoing discussions with the cities and the county government in your jurisdiction, has there been any discussion about any triggers that might be hit as far as numbers are concerned for putting any localized mitigation measures in place?
We have not had a discussion of trigger level for further mitigation locally.
Okay, that's something that we'd be happy to assist with and discuss. And of course, as you and I have talked about, and as we've talked about here, if there are needs, we would be happy to collaborate with you from the task force perspective to identify some of the mitigation measures that could be put in place. And this is difficult, and we know we're dealing with people's lives and livelihoods, and that's something that I said, I think, in the very first meeting, that we're trying to strike a balance and and working together with you to do that and provide you the support you need. And I would encourage you, and I would encourage you to have that conversation about triggers. I know that there are a number of, the news is pretty good at reporting outbreaks like we read about yesterday in the detention facility and community spread and in localized areas as well. And so I know those things are out there and they're challenging, but if there's any support we can provide from the task force in terms of providing you support that you're not getting otherwise, we're happy to do that.
Thank you, Chair Cage, appreciate that. And so we'll explore that and we'll keep you posted with our updates at future meetings.
Okay, great. I appreciate that. I'd like to open it up to other members at this time regarding the Washoe County, the update on safe gatherings from the local health authority. Okay, I'm hearing none, so we will continue on. Thank you very much, Kevin. I appreciate it, and thank you for joining us. And I'll follow up with you regarding any follow-up items that may be discussed from this meeting. And of course, we'll have a number of meetings between now and the next get together as well. So thank you very much.
Sounds good. Appreciate you accommodating my schedule today. Thanks. Thank you for that.
Absolutely. Director Reynolds?
Caleb, just a comment. We were in contact with Carson City Health and Human Services. We did supply the health officers our overall checklist that we developed through OSHA for their use. We also sent several sample plans that we thought were very good so that they could use those as a guide. So they have been reaching out to us and working with us on that. And so we offered to help them any way we could in terms of review and the criteria that we're looking at when we look at a safety plan. So I hope that helps. We did get positive responses back on that. So, but we're willing to help if they need additional help.
I appreciate that. Thank you very much, Terry. And yeah, I spoke to Director Aker yesterday and just didn't work out with their monthly, with some monthly meetings that they had today. But yeah, they've been doing a great job with all the quad counties to pull together as a local health authority. So
yeah, Lyon County has submitted their plans to us on a regular basis. And Churchill County has also, and so we are actively reviewing those plans and giving feedback and getting them back. And they've been very good in terms of adopting the criteria, especially Lyon County, that we have suggested to them.
Excellent. Excellent. Right now, I'd like to open up the conversation to the Southern Nevada Health District, if we have a representative from them to provide us an update.
So this is Misty Robinson. I want to check and see if there's anybody from SNHC who can speak better to this subject. Otherwise, I can speak to it. Okay, it sounds like there's no one here, but with my limited knowledge on this subject, and also we're competing against our Board of Health meeting, which is probably why nobody is on. But we are working collaboratively with the county on getting plans reviewed and sent to the state. The county has released guidance for plans development and where they need to be sent. Our Environmental Health Division has developed an internal protocol to review these plans. I don't have specific numbers, but I do know that several shows on the Strip are returning, as well as the UNLV UNR game at Allegiant Stadium on Halloween. Their plan was approved as well. And that's all I have.
Thank you. And again, thank you, Misty, for stepping in there. This really is just to provide an opportunity for us to have this conversation here in this setting and to continue to make sure we're working across the board with emergency management, local health, enforcement, and others. So any members of the task force who'd like to provide additional information or additional comment? Okay, thank you very much. We'll close out agenda item number 6. And we will go to agenda item number 7 for Director Whitley to provide an update, Director Whitley and Administrator Sherrick to provide an update on the progress in developing recommendations to streamline the system for reporting laboratory data. And then if we could also include in this any of the reporting issues related to the rapid tests in nursing homes and the ongoing discussion we're having with the federal government on reporting those tests as well.
And Melissa Peekbold will be providing that.
Thank you. Melissa will be providing that update. Thank you. So go ahead, Director Whitley or Administrator Sherrick.
Thank you, Caleb. This is Melissa Peekbold, and I'm going to fill in for Lisa Sherrick today on the ELR reporting. Can you hear me okay?
We can hear you. Thank you.
Okay, great. The first note I want to mention, Julia Peek has already alluded to this and mentioned it earlier in the meeting, but it's the implementation of the EpiTrax as a statewide system. The progress we've made on that so far is that DPBH Office of Information Technology support staff are working closely with the Southern Nevada Health District IT staff to plan for this statewide transition. And this will be a new lab and disease reporting system across the state. And we hope to have that implemented by 2021. The second note here is regarding regulatory authority and penalties for failure to report. Since the finalization of the template and the policies surrounding the penalties that was imposed last month, overall DPBH has experienced positive results with compliance when working with the labs. In terms of licensure reciprocity with other states, for out-of-state labs, this has not been necessary because all of our labs are working directly with our state to onboard or comply with our reporting requirements. We sent a warning email to a lab on October 6th, and this lab immediately reacted and worked with our IT department and our vendor Inductive Health to become fully compliant. So that's really great news. And I'll just say that overall, it appears that when we get to the point where we have to send a warning email that outlines the policy and the surrounding penalties, that the labs have worked really well towards compliance with us. The third item here is the development and promotion of a web page that's dedicated to providing this information. And the division has established this web page to provide the listed information, and our recommendation has been fully implemented and no further updates on this piece are anticipated. And that's the end of the ELR update. And I'd like to move into an update regarding the point of care testing in nursing homes.
Please go ahead.
In our skilled nursing facilities, they received the point of care BD Veritor Plus and the Quadelso VO2 testing machines. They've all been shipped to our Nevada skilled nursing facilities directly from CMS. Of our 65 skilled nursing facilities in Nevada, 61 have confirmed receipt of this device. 3, the receipt is unknown, and we're reaching out to them to confirm. 1 has lost the device. UPS records show that the facility signed off on delivery of 4 boxes, including the device, but it's since been lost. And 29 have confirmed that they're actually using the device. We found that the main barriers to use include facilities not receiving their CLIA waiver, the cost of supplies, and that supplies have been back ordered for quite some time. Healthcare quality and compliance med lab inspectors, which are under DPBH, are working to address this with the facilities. We've also provided a background on some general information on the lab certification process and the process for CLIA that we thought would be helpful for the group. All laboratory tests that are performed by laboratories licensed in the state of Nevada are required to have an inspection before they're allowed to perform any patient testing. The CLIA wave tests, such as finger stick glucose in urine pregnancies, are examples of CLIA wave tests. The inspectors will ensure that the laboratory is following the manufacturer's instruction for the performance of the test. They review the documentation of testing, personnel training and competency, and they ensure that the test disposables are monitored for storage conditions and that laboratory safety policies are established and maintained for the staff and the patients that the laboratory serves. For the CLIA non-wave test, the inspectors will ensure that the tests are performed according to the information provided for wave tests, but it will also include required daily quality control, enrollment and proficiency testing, and an evaluation of the validation or verification of the data that is produced for all new non-waved testing to determine if the test will meet the accuracy, precision, and linearity criteria that is established for the laboratory. And the inspector also needs to ensure that the tests performed by the laboratory meet the federal CLIA requirements. Currently, there's 4 point of care tests available under the Food and Drug Administration Emergency Use Authorization. One is the Abbott ID Now, which is a nucleic acid amplification test, a molecular test. And the other 3 are all antigen tests, and those includes the Quidel Sofia, the BD Veritor, and the Abbott Binax Now antigen card. I just want to point out that the Abbott ID Now is the only FDA authorized point of care molecular test. And a positive result on this test is indicative of the presence of SARS-CoV and is considered diagnostic. A negative is considered presumptive. So with this test, in the event of a negative result, they do recommend a subsequent specimen collected and sent to the lab for molecular testing. This is not recommended for positive results on this test. The use of the point of care antigen tests should be reserved for instances where a positive result would direct immediate clinical decisions or infection control measures. So for example, in a long-term care facility, a positive result should trigger isolation of the patient and other corresponding COVID-19 mitigation procedures. The FDA reported these tests as having a high specificity and a moderate sensitivity. And what that means is that these antigen tests are considered to be accurate for detecting individuals with COVID-19, but they're less accurate for correctly detecting when someone does not have COVID-19. And the recommendation from CDC was not to unilaterally confirm all positive antigen results, especially if they're in an outbreak setting, as they're likely to be true positives. But they did recommend confirming by molecular testing of all negatives with concern of false negatives occurring on the antigen tests. And I just want to share the FDA published sensitivity and specificity on these 2 tests specifically. So the Quidel Sofia was at 96.7% sensitivity and 100% specificity. And the BD Veritor is 84% sensitive with 100% specificity. This was based on limited data provided to the FDA. And despite these sensitivity and specificity data, DHHS did recommend that nursing homes perform confirmatory testing on all antigen results, including positives and negatives. And we distributed this guidance to them through a technical bulletin on August 28th. Subsequently, in mid-September, we started to receive reports from SNFs anecdotally that they were having a lot of false positives among their staff and residents. We did an initial survey to systematically quantify this issue, and our initial findings showed about 60% false positive rate in that data set with a 40% true positive rate. Some of the reasons that could have happened is lack of compliance with the manufacturer's protocol, inadequate training, false negatives with confirmatory RT-PCR, especially if the confirmatory PCR test could not be performed within the 48 hours of the positive antigen test. And additionally, low prevalence and incidence of COVID-19 within the community may result in high rates of false positive tests. In response to these findings, Dr. Azam, our Chief Medical Officer, issued a directive in consultation with Dr. Pandori, the director of our state lab, through a technical bulletin on October 2nd, asking skilled nursing facilities to discontinue the use of all point-of-care antigen tests in SNFs until the accuracy of the tests could be better evaluated. The concern was truly that these tests are intended to have an immediate infection control and prevention measure applied. And what that often means within a skilled nursing facility setting is that a false positive, vulnerable individual would be moved into a unit with other COVID patients, and alternatively, someone who could be potentially false negative would remain in that general population of the skilled nursing facility. The concern is that either of those scenarios had the potential to result in harm among this population. I want to just add too that along with this directive, the skilled nursing facilities were also directed to continue to fulfill the testing efforts that were outlined by CMS, but just using a molecular test instead of an antigen test, such as a PCR or the Abbott ID now. The directive was meant to place a temporary pause on the use of the antigen test to allow us time to collect more data and further investigate why we were seeing this high percentage of discordant test results. Subsequently, on October 9th, Nevada did receive a letter from Dr. Brett Gurar from the U.S. Department of Health and Human Services directing Nevada to rescind this directive for SNFs to discontinue the use of the antigen tests. Dr. Gurar stated that Nevada's directive was in violation of the federal law under the PrEP Act. We did comply. Nevada rescinded the directive. However, we continued to further investigate the accuracy of the antigen tests. And I'd like to provide you with the findings so far of what we found to date. So overall, in our skilled nursing facilities that have responded, a total of 9 reported to us using the point of care antigen test and reported those results to us. Of this, this was a total of 50 positive point of care antigen tests were reported and performed. Of that 50, 12 of those were among symptomatic individuals and 38 were among asymptomatic individuals. 36 had confirmatory PCR testing performed. 32 of those were negative, which equates to an 89% false positivity rate. 21 had RT-PCR sample collected the same day of the antigen test. 2 had the RT-PCR sample collected with 1 day of the antigen test, and 3 within 2 days. So all of those, that's just important to note because all of those fell into the time frame to where the PCR would be considered a confirmatory test on the antigen. 6 we do not know, they left the fields blank. 30 of the persons with negative PCRs were asymptomatic and 2 were symptomatic. And of those 2 that were symptomatic, all had antigen tests performed within 5 to 7 days of their onset date. 4 had a positive RT-PCR, which equates to 11% true positive rate. 2 had samples collected the same day that the antigen tests were performed, and another 2 had collected them within 1 day of the antigen test. 1 person was symptomatic, and 3 of those were asymptomatic. And I have this broken out by staff and residents, and I'll just go through this really high level. For staff, there were 28 staff that had a positive antigen result. 4 were symptomatic, 24 were asymptomatic. The total of those that had confirmatory PCR was 24. 20 of those were negative. That's an 83% false positivity rate among staff. 4 were positive. That's a 17% true positive rate among staff. And then among patients, 22 reported positive antigen results. 8 of those were symptomatic. The other 14 were asymptomatic. The total that had confirmatory RT-PCR were 12. All 12 of those were negative. So among the patient in this data set, 100% were false positive rates. We had no positive PCRs. We broke this out by devices, both by BD Veritor and the Quidel Sophia. The BD Veritor had 36 tests performed in this data set. Total with confirmatory testing performed was 24. 21 were negative. That's an 87.5% false positivity rate. And 3 were positive. That's about a 12.5% true positive rate. The Quidel Sophia device had 14 tests performed. 12 went on for confirmatory RT-PCR. 11 of those were negative, so 92% false positivity rate, and 1 was positive, which equates to an 8% true positivity rate. And that concludes my update. I'm happy to take any questions.
Thank you, Melissa. I appreciate that, and thank you for covering both of those issues. I know we have Dr. Pandora here. I wanted to see if you had anything to add to this, not to put you on the spot, but just with your expertise as the director of the State Health Lab.
Oh, sure, Caleb. Looking at historically, antigen tests have existed for viruses such as influenza, for example, and traditionally they have been used outside of labs, obviously, in places like emergency rooms where they provide a differential result, which is to say a symptomatic individual is in an emergency room or a doctor's office, and you want to find out whether the cause of those symptoms is, let's say, flu, for example. And so antigen tests have been used in that way. They've traditionally lacked sensitivity and specificity relative to laboratory-based tests. And the way that they have traditionally not been used is to screen across the board, to look for illness in symptomatic and, in asymptomatic individuals. Antigen tests, as Melissa Peak-Bullock just indicated very well, they tend to lack specificity compared to lab-based tests, and the consequences of that are that when they are used to test large amounts of asymptomatic people, then they tend to provide more false results than true results. And so the real caution here is that if antigen tests are used and they ascertain the existence of positive cases, let's say in an asymptomatic population, to take extreme and great care in getting, first of all, that test confirmed by a lab-based test, but also with regard to cohorting patients, it should not be done until you can be absolutely certain that you have a case, an actual case. So antigen tests are a tool to try to get a fast result, but traditionally have not been used in the manner in which the federal government is asking that they be used. And so I advise extreme caution in the utilization of such tests. There are other rapid tests that are becoming available that are molecular in nature. Again, Dr. Peak-Bullock very well indicated the Abbott ID Now is a different technology. There's another test coming out soon with a similar technology, and those have improved performance. But in the meantime, I advise caution in the use of antigen tests with regard to their performance. Thank you, Caleb. And this is Mark Pandori for the record.
Thank you, Dr. Pandori. I appreciate that. That's great insight for the rest of us. Any other questions or comments or anything anybody from the task force would like to add?
This is Julia. I'll just add that we have, since we provided that directive, we've had the opportunity to talk with Quidel and BD Veritor and looking at training opportunities for our skilled nursing facilities, specifically what does the information mean? And I think Dr. Pandori summarized that well. They have provided us with a number of links that we could provide our facilities to get additional testing and figure out how this would work in their facility. Emphasis has been given to focus on symptomatic and also to focus on staff as opposed to residents. So it is another tool. Point of care tests, I think, are imperative to address COVID. We just need to figure out the best way to use them and interpret them. Appreciate Dr. Pandori and Melissa both for their leadership on this, as well as Dr. Zahn. I'll close by saying we also had the opportunity, I believe it was yesterday, to talk with leadership on the White House Task Force, as well as our federal partners at DHHS. They are ready to help Nevada and all states to figure out how this works. Specifically CDC, though, I do want to acknowledge they've had calls with us and will have regular calls with us in other states to figure out what antigen tests look like specifically in our skilled nursing facility. So I do just want to get on record that our federal partners, as well as the developers, want to help us figure out how this looks for our facilities with the same goal that our vulnerable populations need rapid point of care tests, but we need to make sure that clinical decisions and movement and cohorting of patients is really thoughtful. Thank you. Thank you very much. Any other questions or comments regarding this this update the state epidemiologist provided for all of us? Okay, great. Thank you very much. And thank you, Melissa, for doing that. That was really excellent information and great detail. Really appreciate it. I'd like now to, excuse me, I'd like now to go to the second public comment. I'll just remind everyone that no action may be taken on a matter raised on this item unless it has been agendized at a future meeting.
Public comments may be limited to 2 minutes per person at my discretion here, and comments will not be restricted based on viewpoint. So at this point, I'd like to see if there is any public comment to be shared. A reminder, if you are using the call-in system as outlined on the agenda, you need to press *6 in order to speak. Okay, hearing no public comment, we will now go to agenda item number 9. Before we adjourn, we're contemplating potentially going back to weekly now that we are in a climb. But for right now, we're going to stick, as you know, Directive 33 allowed us to do meetings at the college here. Right now, we're going to stick to the 2 weeks and make sure that we're getting the information in that we need from the local communities and local partners. But just keep that in mind that if we are seeing a continued case climb and situation gets worse, we may go back to weekly to make sure we're doing everything we can to support our local, tribal, and statewide partners. So with that, is there a motion to adjourn?
So moved.
Director Reynolds has made a motion to adjourn. Is there a second?
This is
Jamie
Richard.
Black.
I second. Oh.
Thank you, Director Whitley. Appreciate that. All those in favor, please signify by saying aye.
Aye.
Thank you very much, everybody. Appreciate all the work that went into this, and we'll see you in a few weeks.